Well, welcome everybody. My name is Knut Vegri. I'm Vice Rector of the University of Oslo. And I'm very happy to welcome you all to this Global Citizen Lecture. The University of Oslo has an ambition of internationalization in the sense that we should all consider ourselves citizens of the same global community. So we have this series going on with the aim of educating and giving people a global sense of responsibility, in a way a global consciousness. The term global village was coined some time ago, and in a way, as the world shrinks due to communication of various types, then we are all citizens of the same village. Today's speaker is an excellent example of how this comes about and what requirements and obligations we should really undertake in order to be good citizens of this global village. Kristin Braa and her colleagues have developed and worked with the open source based health information system program, DHIS2, right? District Health Information Service software version 2, which is web-based. And actually, as a result of their work, they were also awarded the Innovation Prize of the University of Oslo. Kristin will show us what it really means to be in the global village, and she's taken it literally. She's gone to the villages, and they have worked at improving the quality of life in rural communities by making modern information technology available. I will not scoop her speech, so to speak. I will leave it to her. But I've followed this for many years, and it's actually, I think, one of the most fascinating and imaginative projects we have going on at the University of Oslo. So, with this, it's a very great pleasure to welcome you all and to give the floor to Kristin. Please, Kristin.
Thank you. Okay, I'm very happy to be here and be able to talk about this project that is so close to our heart, and it's involving so many people at the University of Oslo, especially at the Department of Informatics. I will address in this talk the huge potential that the mobile revolution that is taking place as we speak in the developing countries actually what we can do with it and what we cannot. So, innovative mobile technology improving health in developing countries is the title of my speech. I would like to, since I'm a little bit different from most academics at the University of Oslo, I can just mention that I took my master's at the Department of Informatics. I took my PhD. I became a professor, but then I went 8 years into industry, working in Telenor. As a research director, working with international projects and developed a research and innovation center in Malaysia for the Asian companies. So my background is a little bit different from many others at the university. So it's possible, so that's also global. So I would like to address a phenomenon that has been going on for a while, but not that many are aware of it. Because for us, mobile technology is so common, and we all have mobile phones in our pockets. But we shall not go many years back where the rest of the world, the 5.2 billion people, did not have a mobile phone. Today, actually, there are 4.5 billion mobile phones in developing countries, while only 300 million PCs, so the billions and the millions, but only 11 million hospital beds. So it's a huge discrepancy between the potential that the mobile technology actually possess for the developing countries, and the difference in the development that the computers, the PCs, the laptops are not following the same path, and I will come back to that. As of now, the mobile is the internet device for the developing countries, and that's actually should encourage us to do even more research than we do and more innovation to see how can we utilize this potential to make a difference for 5.2 billion people. If we look at the growth, we can see an enormous growth in mobile subscription. Today, there is actually 79% mobile prescription per 100 inhabitants in the developing countries, while only 25 PCs per 100 households. Then we are talking households, because we are regarding access to a computer. So this is, you can see the growth. We can use India as an example, because there we can see the steepest growth. And India is 1.2 billion people, and it's quite interesting to follow. When I came back from Telenor in 2009, the mobile penetration rate in India was only 24. So when we started to talk about how can people utilize the mobile phones in order to capture health data in India, people were saying, but you know, that will only be for the few, because it was 24%. I don't know whether we can, there is a pointer, but you see here, that's 2009. And look, that's this very, very steep curve, and now it's 229 million people holds a subscription in May 2012. And this data has been cleaned for double subscriptions. So this is enormous growth, and it's said that it's actually the steepest growth ever recorded for any technology. So, but of course, India is an example because they have a so huge poverty base, and it's so we saw it in India before than other places, that this growth mean a lot for the innovation and for the research when you come to utilize this potential. And now Africa is coming after. Absolutely. So we see here that only in one year, like 2011, 142 million subscriptions added. But there is only 4.2 fixed internet connection, and the internet penetration in India is only 11%. And the growth is only 19% of nearly nothing. So internet, as we know it, is not really increasing in India, and that says that we need to focus on the mobile devices and the mobile internet for countries like India, and I also think for other countries as well. For instance, Microsoft have totally giving up the whole big market of India. They are now focusing only on mobile phones. So computers, PCs, they have just leapfrogged it and ending up with the mobile phones. So this HISP project, I call it HISP, Health Information Systems Program, already started in 1994. So we are soon to around 20 years. And it started with a PhD project. Happened to be my brother, actually. A PhD project addressing the need of district health, that's where the D comes from, health information system for the new South Africa after apartheid. That's where the district, so it's an idea of the district is that the data should not only go upwards, it should be information for action. The health workers should be emancipated, get the information back so they can do something with their own situation. But of course, there were fragmentations due to ethnicity and so forth. So we were very soon focusing on integrating all these silos. So already from the very beginning, it was quite new in the way of doing research. This is Action Research Project. I will come back to what Action Research Project is. We are doing research on real implementation. Out of the lab where everything works, into the world where nothing works. So the research we are doing is actually to see how can we solve real-life problems like sustainability, scalability, integration among all this hierarchy, all these donors that want to have their own systems in place in order to report to the people who give money what they achieved, on the burden of the health workers that need to fill out, or maybe you fill out 31 forms in a little clinic, or maybe using a data clerk need to fill in the data 7 times because they have different computer systems and so forth. When the technology was mature, DHIS2, this became open source and web-based. That was in the 2000 3, 4, 5. Before that, it was more standalone, access-based. You had to run around and install on each computer and so forth. After 2000, I would say 3, 4, 5, because it took a while, because we transformed it into an open source program. This software is developed for customizable in the sense it's a framework that is tailor-made to each need, to each country. But it's a framework, and it's every functionality is there, but you can tailor-made it for a particular need for a particular country. It's used for reporting, analysis, dissemination of health data for many health programs. I will come back to what kind of programs: HIV, TB, malaria, mother and child program, immunization program, and so forth. The whole idea is to integrate all the data into a data warehouse to be able to take action. So it's actually for decision making. So since '94, we have been working on aggregate data, meaning statistics for decisions. And decisions should be drilled down all the way down to the health workers that actually is entering the data, in order to address quality of the data, but also address how we can bettering the health service. Since 2009, we have working also with individual data, tracking individuals, tracking mothers through a health program, and then of course that's a different ball game, much more complex and much more difficult, but also very important when it comes to overcome a lot of the big global challenges, as I will come to very soon. Since 1994, it has been spreading, and today it's actually implemented in 30 countries. 30 countries is quite a big number. And it's a national standard, meaning it's covering all the health information systems in the country, managed by the ministry in 12 countries. And we are working closely with WHO. I want to mention a new, actually started in 1st of July this year. PEPFAR, probably you don't know who PEPFAR is. It was actually George Bush that started the largest donor program in the world combating HIV/AIDS. Now it's directly under Obama. It's very huge. Global Fund is working in 150 countries and getting money from everywhere. NORAD, PEPFAR, United Nations, every country are giving money to Global Fund in order to strengthen the country-wise. So they are also they are dealing with 150 countries. And then NORAD, you probably know, that's a Norwegian governmental agency. So these three came to us and said we would like to start a new project, a 3-donor effort, in order to support DHS2 rollout in all countries, in developing countries. And how could that happen from, a little action research project from the University of Oslo? Because they said that every country we come to, we meet DHS2. So it's better to align, then the health workers need to report to PEPFAR on a different system, and PEPFAR need to maintain and pay money to maintain capacity, local capacity, to a competing system. So it's better to align each other. PEPFAR have never talked with the Global Fund on the ground. We are now talking about the two very big donors that are working through a lot of agencies. So for instance, in Zambia, you could have maybe 20 agencies being paid by those two. So we are now the agency in order to harmonize indicators and harmonize solutions. So this is kind of revolutionary. It started in 1st of July, and we are already working in 5 countries together with them. And the innovation prize we mentioned. So what are we addressing? We are addressing the United Nations Millennium Development Goals that was defined in year 2000. It's 16 of them, where 4 of them is about health. It was about how to eradicate poverty in the developing countries. All the world leaders were gathered and agreed on this. And this should be the goal for all the donors in the world. And all the developing countries shall report on these goals. So we are then gearing the DHS2 in order to be able to report on these goals, because these are very important goals. Addressing child mortality, child immunization, mother mortality during maternity or delivery, the big diseases as HIV, malaria, and TB. But also drugs availability. Of course, you cannot do anything without drugs. So these 4 Millennium Goals is quite important, and Norway have taken a lead on especially 4 and 5, mother and child health, is said, together with Bill Gates. And this is one of the reasons that they say now, speculating that maybe Jens Stoltenberg will have a role to play in global health after he's stepping back from being a prime minister. Because in Norway, they started the Gavi, the global vaccine program, that has been very successful, which we also have been funding our project through research. So I just want to show how are we addressing this. Here we can see a lot, we call it a dashboard. So every health leader in the district, even in the clinic, could look at their catchment area and see graphs on the more important indicator. Here we see the reporting rate. First it's the reporting rate. Here we have said what kind of delivery type. Here's maternity death by province in Kenya. So you can actually monitor, and you can see if there's a huge gap or it's a increased, you can take decisions, and you can actually this is a Kenya national dashboard. You can go and drill down to the particular clinic, to the particular district, the province where there are certain problems. And here you can also see that the ANC is meaning antenatal care before delivery. The pregnant woman supposed to go to 4 visits. And here we can see she go to first, but she don't go to the 4th. This is half of them. So this is what we are addressing when we do tracking. We are tracking mothers through the pregnancy, so we make sure so she go to all the 4 visits in order to save her life and the child. And here you can see actually how many has been tested during delivery for HIV. 53,000 women during delivery in 2012 in Kenya. So many, some few thousand less are actually accepting to take a test. And here the positive is more like 5,000–6,000. So this kind of monitoring can be done in every level. I just want to see how we kind of address these goals. So what is this project? Action-oriented multidisciplinary research project. Because we are having our PhD students, our researchers are either coming from informatic background or medical background, public health background. Even sociologists are joining in order to understand this kind of processes and governance that we are working on. Our aim is to strengthen the national health information system. We are into public health, so we are not doing a pilot. We want to cover the whole population in order to make a change. That's why we need to collaborate with the Ministry of Health, even though we can start to collaborate with USAID or a donor, but then we do it in order to be able to show by example what you can do in order to attract the other donors, and then eventually building up a demand in the ministries. Because maybe they didn't know it was possible in the first time. So we do it in many different ways. So what is this action research project? Our idea is to build capacity locally. We have 5 international master programs, either in the medical faculties, like public health management or health informatics in the IT department. And we recruit PhD students from there, but we also recruit PhD students from the ministries. At present, we have 32-ish. I would say ish because very many are finalizing the PhD or defending the PhD this year. Actually, we have sort of 7 this year. Altogether, 22 people have been taking their PhD through this program during these years. And they go back and have career locally, either in the ministry or professor at the universities, or maybe having a consultancy and make a living from this. So this is growing as we speak. We also work with building capacity through regional academies. We have where we teach cadres, trainers of trainers, so they can go back to their country and train the others. We have in East Africa, West Africa, Asia, and Latin America. That's very, very important tool where they also tell country stories and learn from each other. So this avenue has been, in the beginning, NORAD was funding it. Now it's self-sustainable because people are paying, or donors pay them to go. So that's a kind of how we work. So the research team that we are working on is interoperability. How can all these silos talk to each other? How can we link up with the legacy systems that already are in place? How can we link all the health programs? Why Global Fund came to us is because they saw they've been strengthening all these disease programs, which is having loads of money, but there is no money for mother and child health. And they saw that there is quite important for pregnant women when they become HIV positive, that they will also have a mother program and a child program. So they actually saw that they have been doing bad by pouring all the money to the disease programs. They need to strengthen the nation in order to take leadership of their own country. So that is actually a new development that is quite important, and it's very, very revolutionary for the way of doing work on the ground. We are, of course, doing research on scaling. And for instance, in the Research Council of Norway and other places, they say scaling is not a research topic. If it works one way, you can do a pilot. No, this is different from pilot, because technology doesn't really scale in itself. And work practice doesn't scale. And you cannot change anything if you don't understand what is actually in place when you scale. If I have time, I will come back to it. So this open source software development is heavily coordinated through a group in the Department of Informatics, University of Oslo, but it's a global network. So we have nodes in Tanzania, Vietnam, India, South Africa, and so forth. Here's just an example of an academy in Entebbe in Uganda in June. And here's the map of where we are. Green, national systems. Yellow, statewide, district-wide, covering parts of the country. And the other color, the lighter yellow is the only starting up. What I would like to address here, I mean, it's 30 countries, is a lot. But what is important is actually that we call it network or action. We are collaborating with all our partners. One of our partners is the West Africa Economical Union, including 15 countries. And those 15, now, because the Millennium Goal, meaning you report to WHO. It's a global leadership combating poverty in developing countries. What ECOWAS asked us to do, to help, is to create a regional leadership. So now we are making a regional DHIS instance for these 15 countries, so the region can take leadership in their own region. And that is happening as we speak now. Then the East Africa community, which is here, heard about that, so now they are coming after and learning from ECOWAS. So this is from us concentrating on country by country. Now we are talking about regions, and that's quite interesting and quite important development when it's come to see how this network evolved, but also in order to address the development goals. Because then, in order to combat maternity death and child death, and HIV and TB and malaria, we need to make changes and we need to have local leadership. And it's, by the way, the deadline is 2015. There's only 2 years left to do this. Okay, so this is the backbone, as we said. This is the data warehouse for statistics, for decisions, and so forth, for doing analysis, the analytical apparatus. And then when I came back from Telenor, back to the project in 2009, I said we need to expand the DHS down to them where there is no computers, no computer literacy, no fixed internet, no electricity, because one of the biggest burden of developing countries is actually fluctuating or not existing access to electricity. And we know that mobiles, they can be charged, you know, by car batteries. You can even do a biking, you can have solar. It's very easy, and especially the low-end phones can last for a week. So we started the work in 2009 to see how can we go from district to clinics to community health workers, but all the way to the villages. And we know in developing countries, 80% of the population lives in rural areas. In rural areas, the roads are bad. Hardly any electricity, no fixed internet, but one thing is sure, mobile internet and mobile technology works. And that is a huge potential for development and for research and for innovation. So from 2009 and until now, the technology has worked for us. So we started actually by, now I don't find by developing apps on Nokia phones, on Java-enabled phones. We made it look like the forms they already did on paper, as similar as possible, and we started to build competence ourselves and to build capacity locally on how we can do that. That was the first we started with. But then we see that the Huawei, the Chinese handset vendors, they become cheap. They produce cheaper and cheaper handsets on smartphones, either high-end smartphones or mid-range smartphones with open source Android platform. So now we can do a lot, much more. But we cannot buy phones for everyone, and in practice, what we find is actually those guys. These simple phones that only can do voice calls and SMS. So we are back here to do SMS solutions in an innovative way. But what we do is all of them. We need to cater for all the range of the use cases due to address whatever infrastructure there is, whatever they have in the pockets, and in order to leverage on what the install base, as we call it. And then, of course, that's not very easy to make that. So this is a research topic in itself. How can we do this parallel? Voice calls, SMS sent, Java client with SMS or data, mobile browser, smartphone, tablet, and PC. Because we have low resource constraint. I would like to pay attention to this picture. This is one of our PhD students standing in an electricity pole with no cables. It was stolen. There is no cables here. He's standing there in Malawi. So the beauty of mobile internet is there is no cables, nothing to be stolen, no copper. So that is not that easy so it's actually very robust in a low resource setting. So that's why we started the whole mobile project saying, you know, when we do, how low can we go when it comes to cheap technology that is robust as possible in a low resource constraint? I mentioned this, I don't need to go into details. Time is flying. So what was our idea? We went out, we took picture, what kind of phones do they have and how can we support them? And then we developed a mantra, how low can we go? What can we do on the lowest end and the cheapest phones? Because we know that we have to live with data coming from paper forms. I mean, papers are sometimes best. But we saw that due to transport problems, distribution problems, lack of resources, lack of money, actually there are no forms in the clinics. Often there are not any forms. But also they take long time to go to send the forms. So the delay can be 3 months, or for instance from Malawi, where the roads are very, very bad, it's a lot of flooding, they sent the forms and they're so busy and they're so overwhelmed with work, so they sent the forms with the ambulance now and then. And when it comes into a car crash, they just found a pile of forms from the whole year in the ambulance in Malawi. And they understood. So it's not a very good and sustainable way of sending papers. Take a long time. However, mobile phones take 1 second. And if you have very bad capacity, like or bad mobile infrastructure, as in Nigeria in the beginning, in the north, where we cannot even go there now, but we had a mobile project there, and they climbed the tree in order to send their report as a comprised SMS directly to the data warehouse, and then they can come out and look at the analysis there. So get the data in was actually the first thing we needed to do. And that is actually very important. It seems like, why is that important? Because in order to be able to take leadership in your country, you need to know the situation and what to be done. And here we see LMS, it's logistics, human resources, and so forth. So here we see it can come out maps, graphs, and dashboard, as I mentioned. Okay, so how do we work? I talked about this action research project, network of action. I would like to pay attention to one of our success stories. We have many of them, but I would like to dwell on Kenya, since we say that low resources doesn't necessarily mean low quality of the innovation and the technology. Because Kenya was the first country in the world utilizing cloud computing and mobile internet to have a national-wide information system. So we worked with Kenya, and it's interesting because it happened by an accident. We started the implementation in Kenya close to 2 years ago, and we were testing the internet. There were a lot of problems with the internet, and because every time the power went off, the internet goes off. But the mobile internet, that doesn't go off at all, because they have either solar or generators on the towers, because the mobile industry, they know how to serve their customers. That's a very good industry in that way. They know how to earn money, and they also know how to serve their customers and make the internet or the network work always. Not always in Norway, though, but in developing countries, yes. So by an accident, we saw that people actually had dongles, mobile internet, and that works. When the internet was down, they had their USB stick, and they just surfed, you know. And then we said, wow, we can actually use mobile internet to covering the whole country. So in very few months in Kenya, covering the whole area of Kenya, and in Kenya you have very many very rural provinces that actually only send the data, and they see the data maybe 1.5 years after in a yearbook, and they don't have a clue of their situation in their province, nor compare it with others. So then suddenly, in 7 months, we were able to get whole Kenya up using mobile internet, cloud supporting, and we had the data in the cloud, so we could actually support the country remotely. So they were then able to log on to their DHIS and see the situation, and that increased the awareness of the data enormously, because now they could actually and it become competition between provinces, competitions between facilities, who's actually having better capturing data rate, but also how they're doing. So they actually utilize it for the first time, and very, very active users. So Ghana actually learned from Kenya. They went online in 2 months. In 2 months, they were able to do the same as Kenya. Also, they had a very, very bad access-based, not only online system, so we could actually transform the data immediately. But they learned from Ghana. And then Uganda came after, and then they used longer time, much more politics, and they also have much more politics around ownership to the data, because data is power. So in Uganda, we were able to make the whole country online in 6 months. But the Minister of Health is sitting on the server, literally, and we are very afraid of letting people see the census data, meaning they don't even want to tell how many inhabitants, population in Uganda, because they don't want to show off as doing bad when it comes to the developing goals. So this is that's a different ball game, but the districts and they are having access to the data. But the NGOs, they are now having big meetings. Even the ambassador of USA was part of this meeting in order to force the ministry to get access to DHIS. But they say no, our data. Quite interesting. So Uganda is very different, but that is the life. We are dealing with different institutions, different politics. And in Uganda, I will come back to very many, we have tons of projects in the mobile project in Uganda, which is very, very interesting. Come back to that. Punjab was the first mobile project that we did a pilot in 2009 of mobile reporting on these low-end phones, only $40 it costed. And the Ministry of Punjab was so impressed, so they bought 6,000 phones for every health workers at the community level. So every health worker have a mobile phone bought by the ministry, and the report now, already in 2009, they have been doing that since then, daily, weekly, and monthly data that go directly into the DHS. But on quite simple and low-end technology. They're still using SMS, comprised SMS, at sending into the to the DHS, because at that time, SMS was cheap, and SMS was only reliable. Late date, they could use data, but they don't trust data, and it tends to stick. Whatever you start with, as we say, the pilotitis, when you start with a pilot, it tends to be the solution forever and ever, because then you need to renegotiate with the operators and so forth. It becomes more expensive. Zambia is also having many mobile projects, and the most famous one is especially the malaria program. And they are doing incident reporting, they are doing stockout, and they are doing reporting where the mosquito net is distributed, where do they have tested for malaria, and so forth. And I was part of training where they actually went all the way to the village, the voluntary workers walking from house to house, testing people for malaria. And they are also reporting on mobile phones. So Kenya I actually already mentioned as the developing country doesn't mean low-tech, because this is pretty high-tech, and we use the latest web technology in order to be able to support one other thing, it's offline support. Because of fluctuating electricity and internet, we need to support the data capturing, the data entry, even though the connections went down. And we would know, remember from the earlier time, that if you lose your data, you never go back. You don't enter data twice. So that was actually the output from Kenya that benefited all the 30 countries in the next release. This offline support, very, very important. Yeah, that's because it's unstable network, you need to do offline support. It's very, very important for the implementation. Yeah. So this example of Punjab is quite interesting. It's been copied many, many countries. It's still the largest mHealth implementations in the world, and it works very well. But again, on a quite simple and old technology. We learn from there, and when we do apps on the phone, now we use mobile data. Because mobile data is available everywhere now. But in Punjab, they don't believe that. And it's also more expensive. And I have been talking since 2009. I said to everyone, why don't you look at the developing countries? It's a huge market over there. It's a huge potential. But the data is expensive. And we know, working in Telenor, that they keep on making the data expensive until the network is stable enough. But then you can also hang on to the expensiveness in order to earn more money. So now it's a global initiative, starting with Mark Zuckerberg, the founder from Facebook. He's now starting a huge, it's called internet.org, where they force the operators to go down on the data tariff in developing countries. Because they look now, they understand. If we shall earn more money, if we shall have more users, we need to go look to the developing countries. I think it's quite late they understood that, because if you see the graph, it has been happening for many years, but now they also, so maybe the data will be cheaper. And that we will benefit from, or the developing country will benefit from. Because when you have a connection, you are connected. So we are also addressing the digital divide, as well as we are addressing health. Uganda, there's a program there called Saving Mother, Giving Life, which NORAD also is in the leadership of. And we understand what it is. It's a program to save mothers. And we are using our technology, our mobile platform, in order to monitor this project in order to see how it goes. But also, it's not about the project, it's actually about monitor the birth and death. Here we see a simple, so now we can actually cover all of them. Because we can use whatever mobile, everybody have a mobile in the pocket, so they can just write death. And then the W is actually a woman in reproductive age. 2 women have died last week. C is actually, you see here, number of infants who died within 24 hours after birth. So it's addressing that very, very critical period in life. And this SMS is going to the national DHIS database and is produced this report. It's very simple, but very, very powerful. And we can also see that this SMS broadcast to this village health team that are out there in the villages, they can then, oh, dear village health team member, encourage all pregnant women to attend antenatal care at least 4 times. So we can actually have campaign. And here is also say, please be informed on the ongoing distribution of mosquito nets is going on. So this kind of message can be broadcasted to all, broadcasted to all these village health team members. This means a difference. So you see here, just to again, stressing the backbone, the data is going somewhere, producing these reports and graphs, and here is the results. So here you can actually monitor then the number of infants who died within 24 hours, the last 4 weeks. And you can compare the different districts in different quarters. So you can see it's one district, Kibale district is doing very, very bad when it comes to number of infants. Also very bad when it comes to mortality of the women. So this is kind of a signal that, so this needs to be addressed in this kind of villages. So those kind of numbers are quite important. But this is low-end innovations with huge impact. Here just another example where you need to, addressing eliminating mother-to-child transmission of HIV. Also very, very important for developing countries with huge HIV transmission to children. Actually, they say that in Uganda, 14 mothers are dying every day during delivery. So this is, I mean, every life saved is important. And this is also very, very high on the agenda. So here just another example that is actually used by 2,400. And here we see that we can also, we are also monitoring the stock availability. Because without the kit available, you cannot do any testing. Just the same example, but a different one. I need to tell you, because this is actually developed by a master student in our department. This SMS solution, he was in Uganda and he developed this solution, and now it can be utilized for all the 30 countries. So we are, the network is not only consisting of PhD students that do the empirical work in their own country or in neighboring country or in the region, but also master students are taking part in this development. We have a big open source course where they actually do tasks within the DHIS development, and the best one is committed to the code and will be then utilized by 30 other countries. This is a more high-end project because I said high-tech, low resource, big impact. But you know, stretching and tweaking that existing technology is high-tech. And it's research-based. But here we also see, in Kenya, we also use the latest browser technology, cloud technology, and so forth. In Uganda, we are tracking pregnant women. And I mentioned that this during this Saving Mother, Giving Life project. And here, this is an integrated service for tracking mothers and children through pregnancy, delivery, and during the immunization period. So we are using PC, tablets, smartphones, feature phones, SMS. And because people are lost, people are moving, people are, they got alerts to come back to clinics. But so this is actually addressing all those mothers that are visiting once, but not coming back for the next and the next and the next, because in order to address mortality for mothers, you need to go to 4 checkups. That's research-based evidence, obviously. So how to best remind the mothers. So these are ongoing projects that we do now under the DHIS tracker. Okay, so here we can see how you can use smartphones or you can use feature phones in order to be able to find a person, enroll a person, and add relationships to the person. If you don't have a mobile phone, a relationship should be your child when it's giving birth, but it could also be a relation how to get contact. And here we have also apps on smartphones to make it easier. Again, when we first tried this out in Uganda, we tested both a PC-based solution and a mobile solution, believing that PC is much better because you're much easier to navigate, much easier to get an overview. But, however, the clinicians and the health workers found the mobile phone much easier to use because they said, that was a surprise for us because they said the mobile phone is the computer of the Ugandan. So that's what they actually preferred because they had never used a PC before. And you know all the viruses and everything you need to deal with. However, doing mobile innovation, doing mobile mHealth, we should never forget leveraging on the social network because the social network is there to be supported. And mobile phone is about communication. Even internet, of course, is about communication and social media. This is just an example from Andhra Pradesh, all the voluntary health workers that go from house to house, and the only money they get is when they can take a child into immunization. They got a prize for one, and when they can bring a pregnant woman into a hospital. So here you can see they were quite, actually after me visiting there, I'm over there, they went on strike because they couldn't survive. And they were working same time on the tobacco plantage. Back to reality, or a different reality. So it's about communication share. We should never forget that is the communication power of the mobile phone. We actually, but we're not always able to do that. In India, we negotiated with the operator a closed user group, meaning that the whole network, health network, could call and SMS for free because operators are earning money on incoming calls. So it's a good business model, actually. And they do it in Norway also, or family and friends. But in business applications, they do offer this for big companies. So there we saw that the largest effect of our implementation was actually the efficiency of people to get in contact with each other. Also, of course, before they would have to send a letter in order when it was an outbreak, they needed to send a letter to the nearest public health center, and then they have to walk out to the village to get the health worker into a meeting, and that could take 3 days, a week. Now they just send an SMS or call. So just having the contacts available means a lot. And also, it strengthened the social capacity of the health workers, because in India you are regarded, some places you are regarded unclean, so they cannot come into the house. But if you can make decisions on the spot, you can call your supervisor, you can actually make decisions, then we saw their social status increases, and they, of course, it helped them a lot in their work. So the communication feature we should never forget, and that's very important, and we work on that because we embed social features in the software. Here we have one very, very important thing. For instance, all these graphs we saw, if you, for instance, are sitting alone in a province, alone out in a rural area, you really wonder, how can I get people into the 4 ANC visits? And they post it, and people are then commenting. So this is actually it's heavily used in Kenya and Ghana. They are very mature users. Ghana actually won 2 prizes. First, they won a national prize, then they won a Pan-African prize in the best HIS implementation in Africa. And that was because they used this interpretation so much that the quality of the data increased. Because now they could actually shine, and that is what's happening in social media. You show that you are interested in your data, you learn from others, but people were active because they saw the manager were actually also looking into who was actually active, who was not active. But of course, they learned and they become much more aware of the data and discuss the data and the reason for why this happening and so forth, and learn from each other. So this is a very beautiful way of embedding social media into the software system as such. And there is many other things we will do, and we are doing it. We are also creating this messaging. So people, in the beginning, it was the kind of user support of technical stuff, and now later it's more domain-specific support. So now they are discussing with each other. They can send to circles, they can send to individuals, or they can send just upwards. So this messaging, this social media, these social features, embedding this is also a research topic for us in order to make people active about the data and address the quality of the data and what to be done. You cannot read it because it's too small font, but you can do it later. I can see people are, I've been talking for quite a while, but I would like to just dwell a little bit on the pilotitis M-Health drama going on, because there's a lot of money out there. A lot of donors are throwing money after a technology project, and we can see the M-Health area as the most technocratic, meaning you are doing things for the sake of technology, not to solve the problems. So we meet M-Health project everywhere, and people don't really understand what that means if you don't connect it to a national system, to a backbone, so people can use the data. Or what happened when the pilot is over, when the money is over, no capacity, no technology left, and no data. So the ownership of the data. We can see a lot of incidents or donors that actually sell solutions, end-to-end solutions. For instance, providing both databases, sending very often data to the US or to the UK, mobile phones, software systems, and then the ministry have to pay for their reports. So they have to pay for their own data. And when there is no more money left, there is nothing, nada. So this is the reality. We are meeting a lot of M-Health projects, and we try to educate the donors to see what you really do is to create a fragmentation and to overwhelm the health workers. So but we also see that you have to think when you do a pilot. This is also a research project about scaling. When you do a pilot, you need to think scaling already here, because we learned from India that they actually just bought the solution that we did piloting. We did a pilot just not quick and dirty, but we didn't think about scaling as much as we should. And we see also from other pilots, it tends to stick. It tends to be the scalable solution because you create expectations. And in the global health domain, public health domain, people don't like pilots. They would like to have working systems because we are dealing with real life problems and human beings and very important stuff. So that we don't do anything for joy or for just testing technology. So we see that pilots can be very, very dangerous to do. And the M-Health project that we can see for instance, in Zambia, they actually had a meeting with us. You need to sell your capabilities better because we are now dealing with people that are very, very Americans, that are very good to sell. So they sell to the ministry these M-Health systems that people believe is actually only in these phones. They don't understand that they are creating a new infrastructure, not compatible or integrated with the national infrastructure. So this is the life out in the, we say that developing countries is a green field meaning there is not like all these legacy systems that we have at the Oslo University Hospital. They need to integrate 2,200 systems when they merged. But in developing countries, we have all the donors with their systems, so there's quite a lot of systems there as well. And that is also on our agenda in order to teach people what this pilotitis can lead to. Well, we don't need to go into that. I just want to end by saying that this mess of an action research project that started with low resources, only human resources, no money, nearly, now more money, but our method has been network or action, enabling people locally to train, educate, and do research themselves in order to grow the network. And then other partners are coming in, and they are contributing to the network. I just want to mention PSI. PSI is a family planning NGO. They do mostly family planning. They are present in 50 countries. In January, they came with all the lead developers in order to learn everything about DHIS2 coding, because they wanted in all the countries to report through DHIS, but they also want to contribute. So they are now taking a lead to be able to support us on privacy issues. When we do tracking, it's a lot of privacy issues that emerge. So now they also want to contribute. So this is now the partnership and the network of action is growing with other actors. I mentioned PEPFAR that want to use DHIS for their own reporting, as well as supporting us economically. But these kind of guys at PSI, but also other guys in Zambia that make a living out of doing DHIS2 training. So when I was in Zambia, they said, thank you for making a living for us. They have 5 people that only do DHIS2 training on mobile phones and have mobile projects. And we didn't know them. They just turn up in an DHIS academy. So this network is growing without any control, but with a clear and conscious research agenda that we actually wanted this to happen, but of course it happened a little more fast than we believed. And we mentioned the West Africa and the East Africa, and they are all utilizing the free and open source software without any licenses. So here it's supposed to say high-tech, low resources, big impact, and this is from Bangladesh. And Bangladesh is, we were in the Research Council yesterday and had a big event about water. Bangladesh is consisting of 80% of water, and it's flooding all the time. But one thing is sure, 97% of the country has always mobile internet available. That's quite cool. Thank you.